Local anesthesia is carried out by the application of tetracaine eardrops 32% with a Mirocell sponge left in contact with the eardrum for between 45 and 60 minutes. The handpiece is connected to the laser generator at the source of cold light and to the video camera with TV monitor. The surgeon holds the handpiece in his hand, looking at the TV screen. The procedure is usually carried out in the office. The OtoLAM is designed in such a way that the video camera and the CO2 beams are focused on the same plane. In other words, when the image is sharp on the TV monitor, the laser beam is precisely focused. The surgeons therefore have to learn to manipulate the handpiece in the external ear canal using an appropriately sized otoscope. A test shooting is carried out on a wooden tongue depressor in order to ensure that the system is working properly. Everyone present should wear protective goggles. At the start, the computer suggests default standard working parameters. The doctor can choose the diameter of the tympanostomy and the shooting power. The recommended diameter is 2 millimeters. If the CAE is curved or narrow, access can be reduced, and you should then use a tympanostomy of smaller diameter, but which will close more quickly. It's better not to exceed a diameter of 2.5 millimeters to avoid residual tympanic perforation. The recommended power is 10 watts for a serous otitis, 15 watts for a mucous otitis, and 20 watts for a glue ear. In general, the laser beam is absorbed by the fluid in the middle ear. If too low a power is used, the laser beam is delivered to the same place. The laser is shot on the lower front part of the pars tensor, the usual place for paracentesis. Here the eardrum is perpendicular to the laser beam, which gives a nicely round perforation, and there's no subjacent noble structure which could be destroyed, the ossicular chain for example. The operation is fast and painless. A 2 millimeter diameter tympanostomy heals spontaneously within a month. The operation can be repeated in case of a reoccurrence of seromucous otitis. Office-based CO2 laser-assisted tympanostomy, performed under local anesthesia, provides middle ear ventilation for several weeks without the insertion of a foreign body in the eardrum. We used it to treat patients with chronic OME that persisted for more than 3 months despite conservative treatment, medication and/or physiotherapy. We did not associate any other treatment, systemic or topical, to the CO2 laser-assisted tympanic membrane fenestration. Had these patients sought advice prior to our disposing of laser equipment, we would have performed office-based ventilation tube insertion under topical anesthesia. Used as sole management for 60 chronic OME, this technique allowed us to restrict the insertion of a transtympanic ventilation tube to only 5 adult cases out of 31 and 6 pediatric cases out of 29. Literature reports a success rate between 40 and 64% for tympanic membrane fenestration in children and between 60 and 84% in adults. We believe that CO2 laser-assisted tympanic membrane fenestration should be initially attempted when the patient's age permits cooperation during surgery under topical anesthesia. Instead, we advocate initial insertion of a ventilation tube for cases that require a lengthier middle ear ventilation. Cleft lip and palate, craniofacial malformation, recurrent OME occurring in the immediate period following the extrusion of the ventilation tube, chronic adhesive otitis media, and severe tympanic membrane retraction.